Everyone. Today in this video, we are going to discuss about chest X-ray interpretation in pediatrics. So in this video, we are going to discuss about the chest X-ray interpretation of a pediatric patient. As we know, most of us are not well aware of the interpreting the chest X-ray. So today in this video, we are dealing with the chest X-ray interpretation. Firstly, when we see a chest X-ray, we have to see what is the view. Either the chest X-ray consists of three view. First is the AP view, then is the PA view, that means anteroposterior view, then posterior view, lateral view, and sometimes decubitus, left decubitus view. So first we have to see what is the difference between AP view and PA view, and when AP view is taken and when PA view is taken. So how do we divide it? How do you get to know that this is a PA view and this is a AP view? Next, we will go to the lateral view. So first is how to interpret a AP view, and either this is a AP view or PA view. First, in PA view, that means posterior anterior view, the beam is come from the posterior part. So when the beam is come from the posterior part, it is PA view, and the film, chest X-ray film, is in the front and it is in the chest wall of the patient. So in PA view, the beam is come from the back. In AP view, the beam is come from the front. So where from the beam is come, that is the view. That means in PA view, the beam is come from posteriorly, and in AP view, the beam is come from anteriorly. As the beam is comes like this type of divergent, so which is near to the X-ray film, these things are we see and identify it is very clearly, and which is away from the X-ray film is we see it in a magnified or zoom like structures. Why it is very important? Because in PA view, the heart lies in the anteriorly, it is closer to the X-ray film. So the heart shadow, it is well demarcated in PA view, and it is in the heart structure is not magnified, and it is just like as it is, and every heart structures is well defined in PA view. So when we are dealing with, we are interpreting heart problem, we have to take PA view. In AP view, as the X-ray film is away from the heart, here is the heart and it is away from the heart, so there is a magnification of the heart. So heart is look like it is in big shape, big, and it is ill defined. So heart is just look like a cardiomegaly, so there is a magnification of the heart, and heart is look magnified in AP view. Next, the cervical spine or the vertebra. The vertebra is more closely to the X-ray film in AP view. So any problem in the vertebra, we are dealing with seeing in AP view, and in PA view, it is away from the X-ray film. So the vertebral problem is not well understood in PA view. Next is the rib cage. The rib cage is look like this, as this is the posterior part, posterior and anteriorly. In PA view, the anterior rib cage is closer to the closer to the X-ray film. So any problem in the anterior rib wall, we have to identify it in PA view, and any portion which is in PA in anterior posterior view, the film is in the posterior. So any problem in the posterior rib cage, we are seeing in AP view. Next, the lung. So lung is everywhere. So in AP view and also the PA view, we can see the lung as it is. It is not having no problem. Now, how to identify? This is a PA view and this is the AP view. As we see the patient is in PA view. The patient is doing when we are doing PA view. So the patient have to extend his arm like this, and as the patient is extending this hand or abduct the hand, so the clavicle is going to like this. So clavicle is just going horizontally, but in case of AP view, as the we have to squeeze the scapula. So that's why the clavicle go outwards and rotating to the upwards. So the clavicle is go like this. So there is the angulation on the clavicle in AP view, and in P view the clavicle is just like more like horizontally fast. Second, the border of the scapula. As I say, we are in AP view, the X-ray film film in the posteriorly, and we have to squeeze the scapula posteriorly. So there is the scapular margin is come to the lung field of a patient. So this is the lung field, and the scapula is come in the inner border of the scapula, come in the lung field of the X-ray. But in PA view, as patient is abducted the hand and the scapula is going outwards, and the scapular border is away from the lung field. Third is the rib cage. We as we see, the patient is abducted his hand outside it, and in AP view the patient is squeezed the scapula. So in case of AP view, the anterior rib cage, this is the posterior rib cage, and the anterior rib cage is like most likely horizontally. It is placed horizontally, and in case of PA view, it is goes angular type. Anterior rib cage is going angularly. So rib cage is mainly angularly placed in PA view, and it is more horizontally in AP view. And there is a apparent cardiomegaly in AP view. As I said, there is a magnification of the heart shadow. This is called casting shadow effect. This is called casting shadow effect. And in PA view, the heart border is well demarcated and there is no cardiomegaly present. So by this, we can divide it into AP view and PA view. And in normal X-ray, when we are taking normal X-ray, we have to take it in full expiration. At the end of full inspiration, we have to take the chest X-ray. So normally, ideally, when the patient taking full inspiration, we have to take a chest X-ray in AP or PA view. Only one cases in which we have to take chest X-ray after the full expiration. What are the two conditions? First is the pneumothorax. In pneumothorax, we are taking chest X-ray after full expiration and also the foreign body. Why? During the full inspiration, the air is entered into the lung field, and lung field look like more radiolucent, or that means black. If in pneumothorax, we are dealing with a area where there is no air is there and there is a black area. So if we take to make a contrast, we have to taking in a full expiration, because during expiration all the air from the lung going out and all the FRC, that means functional residual capacity, is present in the lung field. That means during expiration lung getting squeezed, and if there is a pneumothorax is there, then this having some contrast with the normal lung field. So to take the contrast, we have to do pneumothorax, and also in the foreign body we have to take it in a full expiration. Now, what is this view and what is this view? As I said, the clavicle is placed, it is just like an angular portion, and secondly, the rib cage and anterior rib cage are placed, it is in an angular position, and lastly the scapula border is away from the lung field, so it is a PA view. And in this area, the scapular border is enter into the lung field. The clavicle is mostly horizontal, and the anterior rib cage is just like horizontal. So this is a AP view. Now, after identifying the PA view and AP view, which patient we are doing AP view in, we have to do the AP view when we are taking any problem, we are dealing any problem with the vertebra. If we are dealing with a problem in the vertebra, so we have to do it in AP view first. If the patient is unable to stand or sit, then we are dealing with AP view. And if the patient can stand or sit, then we are doing PA view. Now, after that, the exposure. Does the exposure is well exposed? It is normal exposure is there, or that means the penetration of the X-ray beam is normal, or it is the over penetrated or under penetration of the X-ray beam. We have to get to know. How do we get to know it is a normal exposure is good, or it is under exposure, over exposure? So normal exposure having 3 points. First point is the cardiac shadow. This is the cardiac shadow, and this is the bronchosvascular markings. The white markings is the bronchosvascular markings. In case of normal good exposure, the bronchosvascular markings is also seen in the cardiac shadow also. So in we are seeing the bronchosvascular markings in the cardiac shadow. First point. Second point is the vertebra. So this is the pedicle of the vertebra, this is the pedicle of the vertebra, this is the pedicle of the vertebra, and this is the intervertebral disc. The white black portion is the intervertebral disc. So if we are seeing intervertebral disc between the heart shadow, behind the heart shadow, then it is a good exposure. And third point is, if we see the aorta, this is the arch of aorta. So if we see arch of aorta and also pulmonary vasculature in the cardiac shadow, then it is a good exposure. So these are the 3 points. If it is present, then it is a good exposure. Now this is underexposure and this is overexposure. Why underexposure? There is a more white area is seen, and the rib and the vertebra is not seen. The aorta is not seen. The bronchosvascular markings is also not seen in underexposed area, and the lung is look more white and diffuse infiltration is there. It just look like a pneumonia. So this is underexposure. Even in overexposure, the cardiac shadow, the vertebra is seen, but the intervertebral spaces is not well properly seen. The vascular structure is not also seen behind the cardiac shadow, and the lung is just black. There is no bronchosvascular markings. Is small amount of bronchosvascular markings are seen. The bronchosvascular markings is not seen, and the lung is more black. So it is overexposure. Now after the exposure, the rotation. Now come to the rotation. How do you see the rotation? Is there is any rotation is there or not? First, we have to take a midpoint, that means the spinous process of the vertebra, and we see the medial border of the clavicle. So we have to take the distance between these two. If the distance between the spinous midpoint between the spinous process and the clavicle, if the distance between these two area is equal, that means there is no rotation is there. But if the distance is decreased in one side, that means rotation on that side also. As we see, there is a distance is smaller in this right side. That means there is a rotation on the right side. Now after that, these 3 things we have to see before describing any X-ray. That means that is the exposure, the view, and the rotation. After that, we are describing the X-ray in 8 points. First point is the position of the trachea. The position of the trachea is in the midline, is just right side from the midline, and this is the black markings, and there is a carina is there, and the trachea start from C2 level and it goes up to T4 level. So C2 to T4 level, the trachea is there, and in the T4 level there is a carina is there. So there is a diversion, there is a carina level. So trachea is divided into 2 parts at the T4 level. It is very much important. Why it is important? When you give a endotracheal tube, we have to see the tip of the ET tube should be at the carina level. So at the T4 level. If it is more than the T4 level, that means it goes to one main bronchus. Or if it is above the T4 level, that means it is in the T2 or T3 level. That means there is a it is in the vocal cord. So we have to see the T4 level. So this is the T4 level. Next, the branches of the trachea. So this is the right, this is left. The right bronchus is much more straight than the left bronchus, and the angle is 45 degree in right, in left it is 55 degree. So you have to know that angle, because when there is a right arterial dilatation, I will discuss in later on, there is the angle between the left side, it is increasing, that means more than 75 degree. So if when the angle is getting increased in right ventricular, right atrium hypertension. So this is the position of the trachea is very much important. If there is any whitish patches or anything in the right lung and the trachea is shifted to that side, so what may be the problem? That means there is a pooling effect. So that is means either fibrosis on that part or collapse of the lung on that part. If there is any white patch, white area on the right side and the trachea shifted to opposite side, that means on the left side, that means there is a push effect. So this is either due to any mass on the right side or any huge amount of fluid in the right side. But in case of consolidation, that means pneumonia, there is no shifting of the trachea, and this trachea is dealing with the upper mediastinum. So lung, in the chest X-ray, it is divided into two parts, that is upper mediastinum and lower mediastinum. Upper mediastinum up to the carina, it is up from the starting of that means C2 to up to the T4, that is upper mediastinum, and below this is the lower mediastinum. So upper mediastinum is dealing with position of the trachea, and lower mediastinum is defined by the position of the apex. Now after the position of the trachea, now we have seen the rib cage. The rib cage, that means the anterior rib. We have to count the anterior rib cage. As I say, chest X-ray is always taking in full inspiration. So when we are dealing with the chest X-ray, is the chest X-ray, is the lung is hyper expanded or not, or decreasingly expand? How do you know? Because we have to count the rib cages. So this is the posterior rib cage and this is the anterior portion of the first rib. So this is the first rib, anterior portion is there, and this is the posterior. So we are counting, if we counting the posterior border of the rib cages, that means, so the dome, it is the dome of diaphragm. So highest point of the dome of diaphragm, it is contain 8 ribs, 7 to 8 ribs. So during full inspiration, 7 to 8 ribs should touches the mid portion of the dome of diaphragm. So this is 1 rib, 2, 3, 4, 5, 6, 7, 8. 7, and this is 10, 11, and 12. So the 7 to 8 ribs should crosses the dome of the diaphragm during full inspiration, and anterior portion, that is 5 to 6. If there is a more than this, so if the lung, if the in chest X-ray, if we counting the ribs posteriorly, it is more than 8 ribs, then it is hyper expanded. That means the chest is hyper inflated. And if it is less than 7, that means there is a collapse of the lung. That is during the full inspiration. In mid inspiration, it is 1 ribs less than the during the full inspiration. That means 6 to 7 ribs in mid inspiration, and anteriorly it is 4 to 5 ribs. And during full expiration, it is 1 ribs less than this. That means 5 to 6, and it is 4. So this we have to know. So this is the rib. Counting the rib cage is very much important. Next is the crowding of the rib cage and the distance between the rib cage. If there is a crowding of rib cage is much more, in any portion there is a crowding. That means the portion behind below this portion of the rib cage, there is a crowding is there. That means the area behind this, there is a collapse, or there is a fibrosis of that part. Second is the bone texture. Now the bone texture. If anterior portion of the rib cage is look like spatula shaped, that means a huge spatula shaped anterior rib portion of the rib cage, it is seen in mucopolysaccharidosis. If there is a lytic lesion on the rib cage, that is chronic hemolytic anemia, or due to histiocytosis. Punch out lesion is seen in histiocytosis. If there is a beaded shaped anterior portion of the rib cage, that means the anterior portion there is a bead shaped area strings, that is called Rakachit rosary. It is found in ricket. If there is a notch in the lower border of the rib is there, that is found in coarctation of aorta. If there is a white chalky like rib cage is seen, that is white, more denser white rib cage is seen, that is it is seen in osteopetrosis. If there is a the osteoporotic like lesions in seen in X-ray ribs, that is mainly found in ricket, or this may be found in hemolytic anemia also. So these are the pathology in the rib cage also. If we found any fracture of all the rib cages, we think about Ehlers-Danlos syndrome or osteogenic imperfecta. So this is the position of the rib cage or any anomaly of the rib cage is the second point. Now the third point is subcutaneous tissue. If there is a air in the subcutaneous tissue, it is called subcutaneous emphysema. Fourth point is dome of diaphragm. So this is dome of diaphragm, and we have to see the dome of diaphragm, and we measure the dome of diaphragm curvature. If dome of diaphragm curvature is flattened, it there means there is a hyperinflated chest. If the dome of diaphragm the curvature is getting much more, that means that there is elevation. So how do measure the dome of diaphragm curvature? Firstly, we take this is the costophrenic angle, the point A, and this is cardiophrenic angle, this is point B, and we get a straight border, and the highest point of the dome of diaphragm we have take a mark. This is C and this is D. So if the C plus D should be 1.5 to 2 centimeter. If it is less than 1 centimeter, C plus D, that is flat dome of diaphragm. That means flat dome of diaphragm. It is mainly seen in hyperinflated chest, or it may be seen in any pneumonia or pleural effusion just below the lower border or lower lip. Now, if C plus D is more than 2 centimeter, it is called elevation of the dome of diaphragm. Now, we have to divide the dome of diaphragm into elevation into two parts. That is eventuation and that is elevation. So, what is the definition of eventuation? As this picture shows, the dome of diaphragm getting upwards elevated into the lung and going, and the portion below the dome of diaphragm, that is the gut structure, is going also above into the lung field. So this is, so dome of diaphragm consistency is patent. There is no breakage of dome of diaphragm consistency. So this is called eventuation, and it is why it is there either congenitally, there is absence of absence of diaphragmatic muscle, or there is a paralysis of the diaphragmatic nerve, that means phrenic nerve. This is called eventuation. If the dome of the diaphragm is getting up, and but the no gastric portion is going up along with the dome of diaphragm, it is called elevation. It is seen either due to subphrenic abscess, or due to there is a collapse, consolidation, or fibrosis in the lower border of the lung. So there may be a pulling of the dome of diaphragm upwards. So that is eventuation and that is elevation of the dome of diaphragm. If the dome of diaphragm consistency is break, and any portion, gut portion is going from that dome of diaphragm, break portion of the dome of diaphragm, it is called diaphragmatic palsy. Either due to the Bogdalak, it is called diaphragmatic hernia, either due to Bogdalak foramen or due to the Morgagni hernia. In the right side it is Morgagni hernia, and left side it is Bogdalak hernia. Now the fifth portion is the angle of costophrenic angle. So this costophrenic angle is acute in nature and is present both on the right and left side. So this is elevation of dome of diaphragm. Now the costophrenic angle, it is getting obliterated. So if it is blunt, the angle is not there. It is mainly loss of dome of diaphragm is due to the fluid. So any fluid in the dome, in the pleural space, causing dome of diaphragm, causing blunting of the angle of costophrenic angle. So in PAVU, how much fluid presence should be present in the pleural space to obliterate the costophrenic angle? It is the amount of fluid is 150 to 200 ml. In lateral view, it is 50 to 75 ml of fluid. In case of USG, this should be 5 to 20 ml of fluid present to obliterate the costophrenic angle. Now, besides the fluid, if there is a pneumonia on the lower lobe with parapneumonic effusion, there may be a obliteration of costophrenic angle also there. After that, it is cardiophrenic angle. The cardiophrenic angle is also acute in nature, and obliteration of the cardiophrenic angle is seen in fat pad. That means fat in this portion, fatty deposit or lipoma in this portion, or pad means pericardial cyst. That means fluid in the part. It's an incidental finding, or there may be a pericardial effusion. There may be a pneumonia on the right middle lobe, or there may be any mass in the this portion. That is called obturation of the cardiophonic angle. Now after that angle, then come to the cardiac shadow. First the heart shadow. We have, as I said before, cardiac problem or cardiac anomaly or any cardiac problem. If we are seeing in chest X-ray, we have to take it in a PA view, not in AP view. Now first is the cardiothoracic ratio, and before that we are dealing with the borders. This is the cardiac right border. This is the cardiac left border. The right border consists of the upper right border. It is due to SVC. The lower border, it is consist of right atrium and small portion of IVC. The left border is made up of, this is the aortic knuckle. This is aortic knuckle. So this is the arch of aortic knuckle. After that, there is a pulmonary bay area. That means main pulmonary artery is just like this. So this is pulmonary artery area. This is pulmonary artery area. After that, there is a left ventricle. So this is left ventricle, and this is right ventricle, and this is left atrium. This is the main cardiac, the cardiac markings of a cardiac X-ray. Now, when there is a right atrial dilatation, then it goes like this, and it present in the right side. So it look like this, and this is look like a box shaped, and this is seen in Epstein anomaly. That means box shaped heart. If there is a hypertrophy of the right ventricle, so if there is a hypertrophy of the right ventricle, so then there is a upward indentation of upward going the apex, going upwards, and the heart shadow going outwards. So there is a outwards and upwards shadow, and it look like boot shaped heart. So this like this. So this is boot shaped heart. If there is a right ventricular hypertrophy. So in case of right ventricular, if there is a when there is a right ventricular left ventricular, when there is a left ventricular hypertrophy, this heart shadow and the apex going like this, downwards and upwards, and this is a cardiomegaly. When there is a left atrium enlargement, so left atrium is look like this, and there is an enlargement of the left atrium, so it shows like double contour shadow. This is a one contour, this is right atrium shadow, this is left atrium shadow, and the left bronchus going horizontally, and the pulmonary bay area, there is an appendix is there, and the appendix going outwards, and there is a increasing curvature of the pulmonary area. So this is when there is a left atrial enlargement. Now the cardiothoracic ratio. If we suspect a patient having cardiomegaly, in PA view, we are dealing with cardiothoracic ratio. So how do we measure cardiothoracic ratio? This is the middle portion, that is the midpoint of the vertebra, and this is the right border. The most curvature part of the right border, we take a mark. This is A. Suppose this is A, this is B, and this is the left border. The most curved portion of the left, we take a mark. So this is C and D, and this is the dome of diaphragm. The highest portion of the dome of diaphragm, we mark it right dome of diaphragm. We mark taking the a mark, that is inner border of the rib cage. We take a straight border, both the right and left inner border of the left side. So this is A and B. So if A plus B plus C plus D divided by cap A plus capital B, if it is more than 50%, in PA view, then it is cardiomegaly. If it is more than 60% in AP view, it is cardiomegaly. In newborn, if it is more than 60% in PA view, it is cardiomegaly. So that's how we are dividing. We can dealing with cardiomegaly, measuring the cardiomegaly. So after that, we have to divide it, the chest X-ray, the cardiac X-ray into two parts. That is plethoric lung or oligemic lung. Why it is very much important? So any cardiac, any cyanotic heart disease or acyanotic heart disease, it is divided into two types. In my video, as I said, in acyanotic or cyanotic heart disease, so acyanotic or cyanotic heart disease, it is divided into two parts with increased pulmonary blood flow or decreased pulmonary blood flow. So if there is a increased pulmonary blood flow, if there is an increased pulmonary blood flow, that means there is a plethoric lung, or if there is a decreased pulmonary blood flow, there is a oligemic lung. How do you say this is oligemic lung or this is plethoric lung? We see the bronchovascular markings. So this is the hilum region. As I said, this is the main pulmonary artery, and this is the left main pulmonary artery divided into two arteries, two parts, and this is divided into three part. So this is 1, 2, 3, and this is 1 and 2. So this is a hilum region, and lung is divided into three zones. This is the medial portion, this is the middle portion, and this is lateral portion. The bronchovascular markings is mainly going up to the middle portion, not in the lateral portion. If this bronchovascular markings is present in the lateral 1/3, plus if the bronchovascular markings is also present in the apical area also, and the inner diameter of the right pulmonary artery is more than the inner diameter of the trachea is present, that means a increased pulmonary blood flow or increased pulmonary hypertension is there. So these are the 3 points have to there to say there is an increased pulmonary blood flow. Next, if the bronchovascular markings is mainly present in the medial portion, a smallly to the middle portion, but not in the lateral portion, that is called oligemic lung field. That means decreased pulmonary blood flow. Now, why this is important? Because if any area having increased bronchovascular markings, so see this is the bronchovascular marking is present. If it is increasing more and more bronchovascular markings present lateral 1/3 of the this left lower lobe, but it is not present on the upper lobe or right side, it is not present on the left portion lateral zone, then that means there is an increased blood flow to that part only. It is mainly seen in, it is called physiological shunting. It is mainly seen in pneumonia or any inflammation. If there is inflammation, so there is a much more amount of blood enter on that part. So there is a increased bronchovascular marking to that specific part. That is mainly due to physiological shunting. That is called either pneumonia or there any infection. So this is increased pulmonary blood flow. We have to getting know. Now the lung. This lung is divided in, as I say, as we know, the lung having 3 lobe on the right side and left side, there is 2 lobe. There is 3 lobe, there is 2 lobe. This 3 lobe is divided by 1 markings. So we have to know the marking of lung 3 zones. Firstly, this is the lateral X-ray. In lateral X-ray, this is T2. So we take T2 and up to the T6 vertebra. So we take a markings from T2 to anterior portion of the T6 vertebra. This is the major fissure in left side. So this is the left upper lobe, this is the left lower lobe. But in right side, there is a left middle lobe is also there. So this is the T4 portion. T4 up to the sternum, we take a marking straight border. So this is right upper lobe, this is right lower lobe, and this is right middle lobe. This is minor fissure. So in this X-ray, in AP view or PA view, T2 is there. So this is carina at the T4 level, and this is T2 level where there is a cervical, when there is a clavicle is meet. This is T2 level. So this is T2 level, and T6 level, anterior portion of the T6 level. So T6 level, this is the 6th rib. So we take a markings. This is right upper lobe, the right middle lobe, there is a crux, it is right middle lobe, and this is right lower lobe. In left side, that is left upper lobe, and that is left upper lobe, and that is left lower lobe. So this is anatomy. Now the zone. The lung is divided into 3 zones. Zone 1, this is the upper lower border of the and upper 2 ribs. Up to upper 2 ribs, that is zone 1. 2 to 4th ribs, that is zone 2, and below this, that is zone 3. The lung is divided into zone 1, zone 2, zone 3. Why it is very much important? Because if any pleural effusion or any fluid accumulates up to zone 2, it is called moderate. In zone, if it is present only in the zone 3, it is mild. If it is present in zone 1, along with pushing the mediastinum to opposite side, it is massive. So this is very much important. Now the parenchymal changes. Why the parenchymal changes is very much important in chest X-ray? Because there is a 3 types of pneumonia nowadays we are dealing with. That is, first is air space pneumonia, then air way pneumonia, and lastly is the interstitial pneumonia. So in chest X-ray we have to divide it these 3 pneumonia because it is very much important. As the chest X-ray, in a chest X-ray we are seeing these 3 type of pneumonia most commonly. So what is air space, what is airway, and what is interstitial pneumonia? This is the bronchus, and this bronchus is having divided into bronchioles. After that, it is having ended with the terminal bronchioles and alveoli. So this is called airway. This is called airway. So any inflammation or any pneumonia which present in this bronchus or bronchioles, it is called airway pneumonia. And the terminal bronchioles in the alveoli, if there is inflammation, that is called air space pneumonia. That means lower pneumonia. And between the alveoli, if there is a pneumonia fluid is there, that is called interstitial pneumonia. So how the X-ray look like? If there is a pneumonia in the bronchus, so when there is inflammation in the bronchus, then there is a air trapping in that part. So there is a air trapping and also collapse of the alveoli. So the area which is supplied by this bronchus, only there is a collapse. So there is a, and this type of pneumonia is mainly the bronchopneumonia or viral pneumonia. So there is a patchy opacity is present throughout, white patchy opacity may be present throughout the lung field, either bilateral or unilateral. So there is a patchy white opacity infiltrates of the lung field is there first. Second is due to the inflammation of the bronchus, there is a puffing of the bronchus. So there is a there is a higher puffiness or higher puffing of the area. After that, there is a air is getting trapped in that area. That means increased aeration and flat dome of diaphragm. So there is a the lung getting expanded, and there is a hyper expansion or hyper aeration of the lung field. In case of lobar pneumonia, there is the alveoli getting collapsed, and the alveoli, the fluid from one alveoli go to other alveoli from the pore of cones, and so there is a massive homogeneous opacity, and this is heterogeneous opacity, and this massive homogeneous opacity is present on one lung field, that is lobar pneumonia. What is opacity on one portion of the lung? So that is a homogeneous opacity of the lung, and as there is a fluid is present in this area and the bronchus is patent, so there is a air bronchogram seen in between. So there is a air bronchogram is seen in lobar pneumonia, and there is a collapse or there is a white dense opacity, homogeneous opacity present on one lung or one lobe. In interstitial pneumonia, as there is a interstitial means that the spaces between the alveoli is getting edematous. So there is a reticular mesh-like formation. So there is a reticular mesh-like formation throughout the lung field. It is called reticular interstitial pneumonia with reticular mesh-like formation. So that is interstitial pneumonia. When we found any area which having heterogeneous or homogeneous opacity of lung. So any lung field which having heterogeneous or homogeneous opacity, then we are thinking about 5 differential diagnoses. So any homogeneous opacity radiopaque shadow is present in the lung field, we have think about 5 differential diagnoses. First is the fibrosis, then is the collapse lung, third is pneumonia, lower pneumonia or any pneumonia, fifth is mass, and last is fluid filled cyst. Fluid filled cyst. So how to differentiate between these 5? In pneumonia, there may be air bronchocum is present, but in collapse and fibrosis, there is no air bronchocum is seen. But in fibrosis, if there is a mass, if the area is much more, then there may be a pooling effect of the mediastinum. So there may be a pooling of trachea or pooling of heart on to that part. But in pneumonia, there is no pooling pushing effect. If there is a mass, that is well demarcated mass, well demarcated area with prominence of bronchovascular markings. If the fluid is there, so there is a clear cut area is present without any bronchovascular markings. So these are the 5 differential diagnoses of any radiopaque shadow or in homogeneous shadow in the lung field. Now, if there is a heterogeneous opacity present throughout the lung field, which is look like a pin-headed. So pin-headed heterogeneous opacity which may overlap the rib cage also, that is called miliary mottling. Pin-headed any white heterogeneous opacity throughout the lung field, it is called miliary opacity, miliary mottling. So the differential diagnosis are of the miliary mottling is either miliary tuberculosis, asbestosis, pneumoconiosis, or any infiltration of the malignancy in the lung, or any metastasis, or there is maybe a silicosis. So these are the different, or pulmonary alveolar proteinosis. These are the differential diagnosis of miliary mottling. Now, if there is a homogeneous opacity with absence of the cardiocostophrenic angle, there may be a pleural effusion. So how do you differentiate divided pleural effusion? So if there is a homogeneous opacity present throughout the lung field without any bronchosvascular markings, then think about pleural effusion or hemothorax or hydrothorax, anything like this. If there is a meniscus sign, that means S-shaped area is there, that is called meniscus sign, that means a pleural effusion or hydrothorax or any hemothorax. If there is a straight border is present demarcated between the fluid area and the air area, that is called hydropneumothorax. And if there is a if there is a much black area is present in the lung without any bronchovascular markings, then it is due to pneumothorax. So any white lung, any black lung without any bronchovascular markings, it is pneumothorax. This pneumothorax either due to tension pneumothorax, or if there is a bronchovascular markings is present with full black lung, it may be due to emphysema or maybe CCAM. So that's how you can identify the different cause of chest X-ray. So this is for chest X-ray interpretation. Thank you.